Good afternoon. I want to thank SAGES, the program chairs, the session chairs, for allowing me to give this talk coming from a long way here. The one on the left? It's not working. There it goes. There it goes. No interest to disclose. Doesn't seem to work, please. In the meanwhile, we have to thank innovation and innovators because it's not. It goes. Push it down harder. Perfect. Because otherwise, mankind would not benefit, for example, from organ transplantation, cardiac surgery, minimally invasive surgery, ERCP, a lot of medications. So we have to keep an eye of caution whenever we speak and criticize innovators and innovations. Let's move. I want to share with you some reflections on this aspect, and this is the overall overview of my lecture. When it comes to ethics, it comes to moral. And every time we speak about moral, we are going to analyze the surgeon's behavior towards patients, towards society, toward colleagues, and toward other societal institutions. In a very sardonic way, George Bernard Shaw wrote at the starting years of the 19th century about the pecuniary interests of surgeons. Nonetheless, he also went against unnecessary operation and manufacturing and prolonging lucrative illnesses. More behind after that, Ivan Illich, who was a priest, and he finished his days in reclusion in Cuernavaca, close to Mexico, District of Federal, established that most of today's skyrocketing medical expenditures are destined for the kind of diagnosis and treatment whose effectiveness at best is doubtful. So when it comes to speak about ethics regarding any special procedure, we need the data. We need good science to make good ethics. In 1882, Karl Langenbuch performed the first open cholecystectomy. 100 years after that, Erich Muche, as Dr. Strandstrom established, performed the first laparoscopic, and this was not innovation, this was not disruption, this was a real revolution. But he paid a price. The price was he was expelled from the German Surgical Society. He was sued. He spent a couple of months in jail. So that's also the price of innovators and innovation. And it's very difficult to define innovation, but we can paraphrase just Potter Stewart when he defined pornography. You know when you see or when you are in touch with that. McKinley later on described the 7 stages in the career of medical surgical innovation, which is a circle. And if you see, for example, nascent fundoplication, as you have seen during the meeting, there is the 7 stages. The randomized controlled trial is followed by some people abandoning the procedure. There is erosion of support, and then comes another, and this is the cycle. And beware also, because society will profit from innovation and innovative surgery, but there is always a price to pay, and that's the price of medical and surgical errors many times. Every time a new technique is introduced in the surgical arena, we have to give credit if it's feasible, if it is safe, and which are the clinical advantages. And the advantages can be in the sense of the benefit to the patient or to the healthcare system. Besides, in many parts of the world, we have an issue about cost effectiveness. And also the issue about the value in healthcare and who decides on value. Is only the patients in a very autonomous way? Is the whole society, especially in state-run health systems, or are the third-party payers the ones who have to make the payment about the wastes? So also it's important to know that surgical innovation, as has been proven in the previous lectures, is not always synonym of surgical evolution, and override our interest is the issue of patient safety, which is a real ethical concern, as you will see later. Every time we operate on a patient or we give an indication for surgery, there is an ethical challenges, much more when we're speaking about innovation in surgery. First, we have the issue of harm, the threats of the surgical informed consent, which have been overviewed by a previous lecturer, the distribution of resources, and the conflict of interest. And all the parts that are involved in this are the surgeons, their institutions, the professional associations, as well as the whole society as a whole. Let's move then to the surgeon-patient relationship. Surgery is unique. And why surgery is unique? Because surgery harms before it heals, because it is invasive and penetrating, because it's prone to error, because decision-making is most of the time under uncertainty. And besides, surgery is prone to risk, to error, to complications and sequelae. That's what makes surgery so unique. As Professor Pellegrini in his presidential address, every surgeon should have a moral compass. So we have to be altruistic to our society, we have to impose self-sacrifice and be unselfish. Among the surgeon's tenets, humanism and ethical concerns are a must, besides good clinician skills and good surgical technique. And the basis of the surgeon-patient relationship and the moral obligations of a surgeon to his or her patients are founded on trust, which is not a contract, but is fiduciarism, and what this fiduciarism stands for. As Moshe Ben Maimon, a surgeon of Jewish origin born in Cordoba, Spain, he asked God the Almighty to grant his patients to have trust in his art and to follow his prescriptions. More recently, honesty and integrity. The concept of a fiduciary is that who has the duty created by his or her undertaking to act primarily for another's benefit, and that another is a patient in matters connected with such undertaking. In that sense, it's important to bring to mind the figure of John Gregory. He was the one responsible of make medicine from a trade to a profession. And he was the one who introduced long time ago the concept of medicine as a fiduciary profession. So the physician, and in our case the surgeon, must be in a position to know the patient's interests, should be concerned with protecting and promoting the interests of the patient, and should be concerned only secondary with his own interest. So the bottom line is the issue of honesty. And we have to be honest if our surgical ethics principles are going to guide the clinical judgment and practice of the surgical community. Every time a surgeon is confronted with a patient, he has to give answer to these two questions. How to treat, that's a matter of science, and why to treat, and that's related to questions of medical ethics and, of course, of moral philosophy. We have to answer the following three questions. Are there appropriate indications for surgery, especially in the case of innovation? Is the operation in the patient's best interest? And which type of operation should be performed? Remember that the patients have 7 basic rights, 3 which are negative and 4 which are positive. And there is a very thin line in between these rights and issues of professional liability, which are going to be discussed at the courts. The ACS has included in the relation of the surgeon to the patient the conflict of interest, and then has defined the conflict of interest. But very easily we can say, as Rodwin has stated, that physicians and especially surgeons have a conflict of interest when other interests or commitments compromise their independent judgment or their loyalty to their patient. That means that they are no longer autonomous, or there is a breach in their loyalty to their patients. Disclosure has been introduced, but disclosure is not the only solution, that's the final solution, because disclosure does not eliminate the issue of truthfulness and real conflicts, though it's really very upfront. It doesn't negate or prevent erroneous motivation, thereby leading to truth of acceptance. Let's move to the relationship between the surgeon and the society. As Voltaire stated, with great power comes great responsibility, and surgeons are responsible for the dissemination of knowledge among our society. Among the society, we can have examples of distributed justice between the society and each of the individuals, and commutative justice between individuals related to the exchange or attribution of resources. Surgeons are responsible for distributive surgeon. Surgeon must be autonomous over the principles of justice in surgery. That's not many times the case in the present situations of work. And he or she should act according to their moral, legal, and ethical obligations to the patients in the first case, to the society, and to the institutions at the professional association who recognize them as a surgeon. Following the principles of the French Revolution, we have liberty, we have equality, which means equity of surgical care, and fraternity, which is the solidarity of the surgical profession within the society in its merits. It's interesting to recall 50 years ago, Dr. Dunphy, in his presidential address, spoke about responsibility and authority in American surgery, and it can be made worldwide. Surgeons have a collective responsibility to seek the benefit of humanity. Autonomy of each individual surgeon is possible because society is in agreement with surgeons that they will act to benefit humanity. But this is not for free, it's conditional, as he said. The autonomy is conditional because surgeons must have some form of central authority to ensure that the standards of professionalism are complied or met with. So we have, according to Durkheim, the relationship between the society and the institutions of surgeons that is based on fraternity, which can be also defined as the organic solidarity. And each surgeon has a moral and ethical responsibility to the society, and they have professional autonomy in surgery, but they also have a moral duty to comply to these obligations. Regarding advertising, the ACS also has included this in the relationship between surgeons and society. Though it is legal, you will see, and you have to decide on their own if this is ethical or not. Robotic-assisted surgery made me famous, and bringing it to this place around I-95 North makes me proud. Let's move to the ethical principles and concern. These are some of the questions we many times have to give reply. As Beecher said, ideally, all surgical interventions should be controlled, and that is one of the reasons that we do not only need randomized controlled trials, but we need a good database or national, regional, or even international registries, maybe no longer more optional or elective, but mandatory. That's the way we know, and society know, what's happening to their surgical patients. There are differences between research and innovations, as has been stated by the US Department of Health and Human Services, and especially this comes to the relationship, as London stated, of the zero sum. The objective, the target of clinical research is to generate information and knowledge. The target and the aim of clinical practice is to benefit patients and work in the patient's health interest, which sometimes these two aspects are really confronted. Bernie Friedman was the one who introduced the concept of equipoise, the state of equilibrium of counterbalance, which has to ground any randomized clinical trials. And also the ACS have a statement about emerging surgical technologies. Every time we come to surgical interventions, there are formal components and material components. Material components means that the solution for stone disease in the gallbladder is the cholecystectomy and nose operating some place in the brain. Let's move to the formal components where robotic surgery is implied. Formal components can be divided in target endpoints, which defines the genus of a surgical intervention for a determined disease, and the hierarchy of instrumental goals, which can every time be broken in different steps. For example, the incision, how you make an incision. You use a scalpel, you use a laser. How you suture, you use staples or any other additional means. And robotic surgery comes in this type of formal components. The goals or the ones you see there in the slide. Every time we have to think that every new technology entails some additional risk, and our concern is the safety of our patients. The ethical principles, as recepted at the Belmont report, were the work of Beauchamp of Chalmers, who inspired in this paper, The Good and the Right, 1930, from Sir David Rose. And the issue we also mentioned, we cannot access, for good ethics, you need the precise data. Otherwise, it's very difficult to make ethical discussions possible. And this editorial of The Lancet, the true demarcation between the practice of scientific medicine and the lunatic fringe lies in the quality of evidence, not in the nature of the remedy itself. In the case of robotic surgery, the numbers are skyrocketing. 2008, or a little bit more than, higher than 100,000. 2012, those are the numbers according to Intuitive Surgical. A recent ad in the New York Times, in the Sunday edition, and the publication of Symposium of Robotic Surgery brought this issue, and there was a lot of controversies in different blogs and through the internet, and people were emailing each other, criticizing, and making decisions about this. So let's go to the science and to see if the robot is really beneficial or not. This is, for example, a very recent paper from the Annals of Surgery, whose conclusions are a little bit preliminary. This is, as you can read from the slide. But if you go to this, you can have some scientific ground for the conclusions. And the conclusions of the authors is that large randomized trials are necessary to validate the potential benefits of less blood loss and lower margin positivity rates observed in the studies. This paper from the people from Harvard, the first author is Jim Hugh, also brings some criticism regarding the use of the robot. The results show how direct-to-consumer marketing can lead to the explosion of expensive new treatment with little evidence, and that's what we are looking for today. This is another paper bringing some criticism and some critical aspects about the use of the robot. This is a very interesting paper regarding the malfunction of the robotic systems, with more than half of the surgeons experience some malfunction of the robot, and these are things that are not currently offered or disclosed to the patients. This is one of the last one, the group from Johns Hopkins. A total of 245 events were reported to FDA during the study period, with 71 deaths and a couple of injuries, non-fatal, related to the use of this technology. In conclusion, surgery and innovative surgery are characterized by fallibility. Strict adherence to ethical and moral principles is mandatory. Conflicts of interest should not only be disclosed, but set aside from surgical practice. Regulation must be enhanced and fostered by surgical societies, and more reliable methods of assessment of the surgical technology should be developed. Society and public health concern for patients demand more careful scientific scrutiny. Otherwise, most of these issues will resolve in the courts by people who are not that familiar with innovation, surgical issues. I also invite you to the World Congress of Surgery 2017 in my country, and thank you very much for your attention.